Yes, Humphrey, I think we can.
Thank you. So good afternoon, ladies and gentlemen and others. So welcome to the South to South HIV Prevention Learning Network. Zimbabwe is very proud to host this Link and Learn session on behavior change for key population. My name is Humphrey Ndondo. I am the Senior Technical Specialist for Key Populations based at the National AIDS Council of Zimbabwe. The team of the South to South Learning Network champions in Zimbabwe has entrusted me to coordinate the session today. So good afternoon once again and welcome. While we are waiting for colleagues, we have some rules of engagement. Kindly show by lifting your hands. If you wish to speak, kindly also engage with the chat box as much as you can, and also share who is on the platform by sending your greetings on the chat box. So we are going to have the South to South HIV Prevention Learning Network, particularly focusing on behavior change programs for key populations. Next slide. We are very thankful to the support that we have from the Global HIV Prevention Coalition, from the University of Manitoba, from Genesis, just to mention. So in terms of, this is the team that has been the SSLN champions from Zimbabwe. To my extreme left, we have the Chief Executive Officer of the National AIDS Council, Dr. Bernard Madzima, and Ms. Getrude Ncube, the National HIV Prevention Coordinator, who's going to be taking us through a presentation on the contextual overview of the national HIV response in Zimbabwe. Some representatives from civil society. We have Sylvester Nyamatendedza, who's the program lead at GALS, an association of LGBT persons. I am there as Mr. Humphrey Ndondo, the key population technical specialist with the National AIDS Council. We also have Ms. Musa Swindi, who's the executive director for the Sexual Rights Center. We are also joined by Mr. Raymond Yekeye, who was going to give us our introductory remarks. It was the operations director for the National AIDS Council. We have Ms. Anna Machiha, who is our national STI and condoms coordinator with the Ministry of Health and Childcare. We also have Ms. Primrose Matambanadzo, who is the chief of party with the Center for Sexual and HIV/AIDS Research. We also have Mr. Nigel Kunaka, who is the marketing campaigns manager for Population Services International. He's also going to be sharing one of the presentations around a deeper dive on behavior change models for key populations with men who have sex with men. We also have Mrs. Tendai Mbengeranwa, who is our National KP Program Coordinator with the National AIDS Council. So that's our team of champions, ladies and gentlemen. Over. Next slide. So this is the agenda that we are going to go through. So we are going to get welcome remarks from Mr. Raymond Yekeye, who is the Operations Director at National AIDS Council, as introduced. We are also going to get an overview from Ms. Getrude Ncube from the Ministry of Health and Childcare, focusing on the contextual overview of the HIV in Zimbabwe and an overview of the KP program in the country. We're also going to take a deeper dive into the promising practices on behavior change programs for key populations. So we have prepared two presentations, one on using the human-centered design approaches to understand and tailor services for men who have sex with men in Zimbabwe, and the second one on risk reduction programming for young women selling sex in Zimbabwe. The presentations basically follow an outline that will detail the program challenges, that will speak to the program innovations and adjustments. We will also share key considerations made to ensure program success and the lessons that we have learned. We will open for 30 minutes to have a plenary session where we are going to engage with these two presentations. And we also are going to take a summary of commitments from the different participating countries and the next steps. So that will be done by the Ministry of Health and Childcare. and led by Ms. Anna Machiha. Before we get to the overview and the gist of the program, we would like to hear from Mr. Raymond Yekeye as he welcomes us and gives us his opening remarks for this session. Mr. Yekeye, over to you.
Thank you very much, Humphrey, for that overview, and good afternoon, colleagues.
Good afternoon, Mr. Yekeye. We can hear you loud and clear.
Humphrey has already introduced me. My name is Raymond Yekeye. I'm the head of Raymond Yekeye. Let me just say it is a privilege to welcome you colleagues to this session that we are hosting in the Ministry of Health and Childcare, as Humphrey introduced, to this South-to-South Prevention Learning Network. And the title, of course, is Behavior Change Programs for Key Populations. This platform, I think as you have all come to get used to it, aims to provide our countries with an opportunity to gain experiential knowledge from our peers. It also helps us to harness and share good prevention practices, as well as empower our national prevention programs to adapt HIV prevention interventions to our unique regional settings and context. The area of HIV programming for key populations has seen a momentous growth, you'll agree with me, over the years. It has overcome the inertia imposed by structural barriers, particularly in our region, to the HIV response amongst key populations, as well as the attendant challenges of reaching populations on the margins of our HIV response, particularly communities of sex workers in all their diversities, men who have sex with men, transgender patients, those who use and or inject drugs, and those in enclosed institutions such as prisons. Criminalization, stigma, and discrimination continue to drive uptake of services among our key populations. Must increase activity to remove barriers to access to HIV services and create an enabling environment to scale up comprehensive, clinically competent, culturally appropriate, and linguistically sensitive KP programs. Let me hasten to say that language, despite very little discussion around it, is delicate. And language sets the tone to affirm or disenfranchise. Our session today on behavior change for key populations is basically framed within a public health lens to promote the uptake of combination HIV prevention and seamless connection to treatment and continuation in care. As Zimbabwe, we will showcase our programs, how our programs have innovated to create an enabling environment for access to differentiated HIV services for key populations. We continue as a country to entrench our HIV response for key populations within a framework of human rights, placing communities in front and at the center of our HIV response. We are grateful for the support from the conveners and the funding partners for the SSL HIV prevention network, including the Global Prevention Coalition, Genesis, the University of Manitoba, Bill and Melinda Gates, for creating this platform to share and learn from each other what works and what needs to retire in our HIV prevention response. We do welcome our colleagues from Zambia, South Africa, and Ghana to a session of robust and fruitful deliberations. And we'll also look forward to your input so that we can adjust where necessary and improve our program. Let me also take this opportunity to thank my fellow team members who are here, representing the ministry, the civil society partners, members from the community, for their hard work in putting this session together. And your dedication is really appreciated. So thank you very much, and let me hand over to our facilitator. Thank you very much.
Thank you, Mr. Yekeye, for those welcome remarks. We really do feel welcomed. And without much further ado, I would like to invite Ms. Getrude Ncube, our National HIV Prevention Coordinator with the Ministry of Health and Childcare, to take us over the overview of the HIV response in Zimbabwe, and particularly draw a lens on our KP program in Zimbabwe. Ms. Ncube, over to you.
Okay, thank you so much. Good morning, good afternoon, maybe to our colleagues who are here, and have already been introduced as. And what I'm going to do is just to give you an overview on HIV in Zimbabwe, and then the overview of the KP program in Zimbabwe. Next slide. Maybe before I go into that, I would like to acknowledge this program. I mean, the fight against HIV is not only Ministry of Health and NAC who are actually looking at that, but it's all of us, all those people. I acknowledge them because we are where we are right now in our HIV epidemic, where we have reduced the new infection because of all those people who have assisted both the ministry and the National AIDS Council. Next slide. So on the overview of HIV and AIDS in Zimbabwe, Zimbabwe is a landlocked country with about over 16 million people, and within those over 16 million people, almost about 1.4 million people are living with HIV according to the 2019 estimates. And amongst those 1.4 million people, 84,000 of them are children. And looking at it, our HIV prevalence, we are at 11.8%. This is according to the ZIMFIA 2020. And if you look at the HIV prevalence according to gender, we are looking at females having about 14.8%, males at 8.6%. So you can see that HIV is looking at gender, females are really disproportionately affected when it comes to HIV epidemic. And then looking at our HIV incidence, although we are happy maybe on the progress so far as a country, because we have managed to reduce the incidence from 0.98% in 2013 to about 0.45% in 2020. But we need to do more on that, because if you disaggregate our incidence, we find that there are some population where the incidence is higher than other populations. So we need actually to look at that. And then on the TB HIV co-infection, we are at about 62%. Next slide. So looking at the burden of HIV, I've already showed you the statistics. I've already showed you the prevalence amongst the population in Zimbabwe. But then if we go further to look at now disaggregate our HIV prevalence to say, looking at these populations like the key population, we see that the burden of HIV is really mostly amongst our key population. if you look at the HIV prevalence for the female sex workers in a survey which was done in 2019, sex workers estimation is about 45,000 in the country. But out of those 45,000 in the country, 42.2%, that's the prevalence for HIV amongst them. And looking at that, it's actually higher than the national prevalence, which is about 11.8%. Again, looking at the MSM prevalence is 21%, which is even twice than the HIV prevalence in the general population. And we really need to look at how best we can include key populations when we are actually talking about HIV prevention strategies. Do they have access to services? So this is why we need not to leave anyone behind when we are actually talking about HIV. And this actually includes issues to do with behavior change, structural interventions, as well as biomedical interventions as well. Next slide. So as a country, because of those statistics, we actually said we need actually to do something about the KP programming. So it was in around 2015, when we actually started to say, let's find out what is happening among the KPs. That's when we did the size estimation. But already, SESHA, which is one of our NGOs or community-based organization, had already started interventions among the female sex workers. So now we had to include both Ministry of Health and the National AIDS Council to say, what is it that we need to do? So we now have got a national KP program, which is actually looking at how best we can intervene, how best we can reduce new infections amongst the KP population. So Ministry of Health together with NAC came up to say, who is supposed to be doing what? Like if you look at NAC, NAC is actually looking at the multi-sectoral response to HIV and coordination as well. And they are really looking at even community-based prevention interventions where they actually go down with the communities and work with community-based organizations, at the same time providing enabling the environment so that we can function and be able to reach out to the key population. And then Ministry of Health actually oversees on the clinical services delivery, that we have come up with policies which are tailor-made to meet the needs of the KP, and even provides their services, healthcare delivery services, which are actually tailor-made, which are standardized, which is we've got out as SOPs so that we are able to treat and be able to access the KPs. So the programs utilize a community-oriented and peer-led service delivery approach, relying strongly on the partnerships with KP-led. Like already as a country, we've got a KP-led partnership forum, which actually includes all the civil servants. And Ministry of Health and NAC come in that as just technocrats. So we let the KPs themselves find out what is needed for them, what we need to do for them, and we work together on that. Next slide. So this is like we said, we have come up with a national KP program, and to assist the national KP program, we have come up with what we call a technical support committee. So this technical support committee supports the national level as well as supporting the sub-national level as well. So looking at, this is the structure of the KP, of the technical support committee, where already you have heard of Mr. Yekeye and Getrude and Humphrey. And with that, we have got technocrats, the clinicians, communications officer, M&E officer. We have the people who are actually dealing with civil society as well. And then at subnational level, where we want to integrate KP programming amongst public health institutions as well as within the communities around. We have actually KP officers which are assisting the national structure, the national TSC structure, to be able to deliver KP tailored services. So this structure is led by Ministry of Health and National AIDS Council. Next slide. So this structure was set up in 2017, expression of need for technical support when we actually started to say, since we are having new infections coming from this group, which are even more than the national picture of HIV new infections as well as HIV prevalence. So that's when we said, let's actually come up with this structure. And then in 2018, we were able to visit Kenya to learn, because Kenya has got a technical support committee, mainly for technical support unity, mainly for the KP programming. So the lessons which we learned from Kenya, we came down and then we had actually to implement, and we never thought it was going to materialize. Looking at the current environment as well, on how these KPs, they are actually stigmatized and discriminated. But with that together, National AIDS Council and Ministry of Health managed to actually come up with how best we can have this structure in terms of reference on how they are supposed to be working and all that. And in 2020, I'm happy to say in 2020, we actually had a full structure, which you saw those people whom I said, those are actually the members of the TSC. And from there, the implementation of KP programming is actually improved in the country. Next slide. So what is guiding our implementation? What is our service delivery model for the KPs? What is there for our service delivery model for the KP? This is just to illustrate how we work with I told you about the KP officers who are working together with public health institutions in the community. So this structure is sort of like differentiated service delivery, where KPs can be seen at the community, they are referred at the health facilities, they are referred even to the community-based organization. So the PA outreach worker then go on to refer the clients for testing. If you see where there's community services, we've got the PA outreach worker where they refer for testing services, either at the facility or at the community where if they've actually identified them. And then within that, when they test either negative or positive, if they test negative, there are services which they are actually referred to for service prevention services like pre-exposure prophylaxis and all that. But right through why we came up with these peer educators, mobile key population peer educators, is to provide support to the KPs. So support is offered at community level for follow-up and continued uptake of services. If the client tests positive, they are also initiated on treatment at health facility level or at community level, and the support is still, and they are still given support even on the monitoring for viral load suppression. So this is sort of like the model which we are using. The service delivery is cultured in an enabling legal environment and policy framework. So like you can see, public and community testing modalities, and then public and community health centers, so that even in the health centers where we have actually the service providers have been actually labeled to be shunning the KPs, this structure has actually helped us, because when we are training even our KPs, our PA educators, we train them together with the service providers so that they understand the KP KPs, their needs and everything. So this is sort of like the structure which we are using in most of our public health institutions together with our peer-led, KP-led services for KPs. Next slide. So today, Zimbabwe invites SLN to focus the lens on unpacking behavior change interventions for men who have sex with men and young women selling sex. I will hand over to Humphrey. Thank you so much.
Thank you, Ms. Ncube, for that presentation and also the invitation to engage with the following presentations that we're going to have. Firstly, we are going to have a presentation from our colleagues from Population Services International, Zimbabwe. They are going to be particularly speaking to interventions to ensure behavior change programming is particularly responsive to the needs of men who have sex with men. Without much further ado, may I invite Nigel Kunaka to take the floor and encourage colleagues to start engaging with the chat as we are continuing with the presentations. So let's not hold over conversations a long time so we can start interacting with the presentations. Nigel, over to you.
Thank you. Could we move on to, okay. Right, so this is a presentation on understanding or using the human-centered design approach to understand and tailor services for men who have sex with men in Zimbabwe. Next slide, please. So between July and September 2019, PSI Zimbabwe and a consultancy organization called idea.org collaborated with the Zimbabwean community, MSM community, to undertake a human-centered design approach aimed at increasing uptake of HIV services amongst MSM. Now, we were really coming from a background of limited knowledge on the MSM community, and we set out to explore the dynamics of the journey of MSM to accessing HIV services. And we created distinct archetypes based on barriers and motivators to accessing HIV services. We discovered that focusing on moments, the key experiences in someone's journey, mindsets were key to understanding how men who have sex with men connect with HIV services. In total, we conducted 18 focus group discussions, 20 one-on-one interviews, 3 hotspot immersions, and 3 observations across 2 urban areas over a 2-week period in 2 urban areas in Zimbabwe. Next slide, please. I'm just going to have a brief rundown of the key insights that we came up with from this exercise. Number 1, living a double life is a burdensome reality for many MSM, but also a source of strength and resilience. What we found out was because of the nature of the current society and scenario that MSM live in, most people will have to adopt a dual identity in most cases. So you find that Nigel can be someone else when he's within a certain space, and then also has to adopt a certain character to conform to the societal expectations. Now, secondly, kinship amongst the MSM community is immediate, but trust is fragile. Now, I usually like giving an example of a person who goes to a foreign land for this insight. When you travel to a foreign land, the moment you see someone who's coming from the same land as you are, kinship is easier to contact. And therefore, you find that for most MSM, whenever they find someone who has gone through the same challenges as them, it's easier for them to form that bond. Thirdly, the HIV testing experience threatens to reveal the carefully curated life of an MSM. So in short, we really found out that our current HIV testing experience wasn't really conducive for most MSM. There were fears of anxiety, fears of who would see me, and those things would deter most MSM from coming to the facility to access services. And number 4, the fear of social fallout is more powerful than the fear of death. The only thing that was really more powerful than the fear of death was social death. And by social death, we're talking about the fact that since I'm HIV positive, I cannot get sexual partners and I could not get acquaintances. Next slide, please. So we also managed to come up with some archetypes. Now, these are just a way of us to characterize the people we spoke to. And the first one is glass box. To read. This is someone who has recently found a sense of belonging within the LGBTQI community. So you'll find that most of the times they're not comfortable with being identified as an MSM within the broader community. But when we have like drop-in centers and safe spaces, they're actually able to portray their sexual identity. Now we move on to the sexual champion. This person considers himself as an advocate in the community. His own life experiences and struggles has led him to actually want to avoid, to help the next person avoid the challenges that he encountered. So this person is really looking to help. You'll find some people would be active on social media and some people would just be a shoulder to lean on. At the end of the day, this person is taking the burden upon themselves to help the next person within the community. Next slide, please. Now we move on to the flag bearer. Now this is someone who's openly gay and proud of his sexual orientation, considers himself as a leader of the pack and a veteran in the community. This person is someone who has gone through all the trials and tribulations. He will say that I'm confident of my sexuality and life can throw nothing more which I cannot handle. And then we move on to the dual life. Now this person is someone who's met all the societal expectations, including being married and having kids. He's got a stable job and feels proud that he can support his family. But the one thing that also nags him is the fact that he also is gay. And to create a balance, this person will actually be able to have a family and have a gay sexual partner as well. Next slide, please. The next archetype is a conflicted heart. Now, this person is still fighting the feelings that he might be gay because of the things that he has heard as he's growing up. You know, things like being gay is satanic, being gay is wrong. This person is fighting those feelings, but at the same time, he knows that this is what I want. And this is how we came up with the word conflicted heart. And next, we've got the after nine. Now, the after nine is being described by other members of the MSM community as manipulative and completely hidden. He's got a high-profile job and an established family. For him, engaging in gay sex is just an act and has nothing to do with defining his sexual orientation. So these are the 6 archetypes that we came up with from this exercise. Next slide, please. So this slide is just going to emphasize one thing which I want you to grasp. An MSM's state is never static. Over time, he may change and take different trajectories depending on his experiences and corresponding mindsets and behaviors. I'll give an example. For example, the glass box. Something traumatic might happen, and then we end up with the subtle champion, someone who's also fighting for the rights of others. Someone will navigate from the state of being a glass box to a flag bearer, where they feel like they've lost everything else and they've got nothing else to lose. Someone might attain the status of a dual life, where he says that, okay, fine, I know that I'm gay, but I still want to meet and fulfill societal expectations, so he ends up getting married. So these are very fluid states and it's never static. Next slide, please. So using this exercise that we did called the human-centered design approach, we tried to identify opportunity areas where we can actually come up with an intervention. Now, the first opportunity area was shifting social forces from inhibiting to encouraging before MSM even get to the door. What is it that we can do as programmers to ensure that we make MSM take that step to come to the facility? And opportunity area number 2, creating a testing experience that affirms an MSM decision to access HIV services. Now, when we have the MSM come to the facility, what is it that we can do to ensure that they will come for a repeat service? The next slide. Next slide, please. This is how we came up with an intervention called Colors, which I'll go into deep detail. Next slide, please. Right. So the Colors intervention really is a way of enhancing the service experience for our MSM clients. And it's made up of 3 components. Number 1, the community. Number 2, peer mobilizers. And number 3, service delivery. Now, under community, we're looking at a WhatsApp account. We're looking at this as a virtual safe space where we can disseminate information to members of the community, and we can also get that two-way information by getting feedback from the community on how to improve our programming. At the end of the day, what we want to achieve with these social media accounts is to create a safe space where people are free and have that psychosocial support. Secondly, peer mobilizers. Now, these are the people we rely to take that word of mouth and spread the information about colors. Because unlike other interventions, we cannot go on mainstream media and advertise because we would inadvertently out our members. So at the end of the day, we really rely on the peer mobilizers as our foot soldiers to carry out this message. It should only be in an if you know type of way. And lastly, we've got the service delivery component, which I'll speak to later on. Next slide, please. Right, so this is our service delivery component, and it has 3 components as well. Number 1, the entrance. Now, whenever you enter into a church or anywhere, the way you are greeted really sets the table for how you are going to receive those services. So we really emphasize the fact that we needed a friendly greeting towards all our service providers at the New Start centers. We also managed to come up with subtle signage, which I'll show you later. What we wanted to achieve by the signage was to avoid people having to ask where the colors route is. We really just wanted to create an if you know type of thing. You are not supposed to know if you are not the intended recipient with this signage. And then we have the staff lanyards. These staff lanyards have the name of the service provider and are just saying friendly service provider. Now, what this does is that it enforces the fact that we are open to providing a friendly service to all our clients. Number 2, the waiting experience. Now, we all know that waiting has always been a difficult thing, whether it's in a bank, but more so when we're waiting to access medical services. So we try to make the waiting experience less anxious. And by doing this, we established a discrete private waiting area where we placed branding which resonates with the community. We also managed to come up with TVs which would play relatable videos, as well as establish the colors community wall. Now, this wall is a chart where people can just write messages of hope and messages of encouragement to the next person so that we build on psychosocial support within the community. And lastly, we move on to the testing process. Now, we introduced what's known as the test-first approach. Now, by this, we are saying that when the client comes through to the site, the first thing we do is test them, and then we proceed to the pre-testing. What we do is that by so doing, we've cut out the time and therefore reduce the time spent at the facility. Secondly, we've sensitized our providers on how to be empathetic towards MSM clients. And lastly, this is what we call a gift bag, which has HIV commodities, including lubes and condoms. Next slide, please. Right. So this is a slide just highlighting some of the components I've spoken about. To the far left, you can see the Share Your Story poster. So this is just an illustration of some of the posters that have been posted by clients waiting to access services. And to the right, this is some of the branding that we've placed in our colors dedicated waiting rooms. Next slide, please. Right. To the left, you can see these circles. There's one in gold and there's one in green. So these are just examples of the directional signs I was talking about earlier, which are known as subtle signages. And this is our lovely service provider wearing the colors name tag. Next slide, please. Next slide. Right. So to conclude, lived experiences of MSM shape distinct archetypes and their journey to uptake of HIV services. Now, understanding these archetypes presents an opportunity to tailor-make the provision of HIV services and mobilization activities to their unique ways. With these few words, allow me to thank you very much.
Thank you, Nigel, for that wonderful and well-articulated presentation. Without much further ado, I would like to take this opportunity to invite the Chief of Party from the Center for Sexual Health and HIV/AIDS Research, Ms. Primrose Matambanadzo, to deliver this next presentation. Primrose, over to you.
Thank you, Humphrey. And so I'm going to talk about risk reduction programming. I will tell you about the program overall and then take you through the work that's been done to address behavioral risk factors and other risk factors for young women selling sex. So please go through the next slide. I'll give you a brief background and context, and then go through the behavioral risk factors as well as others, including medical and structural. There's often a narrower focus on behavior change, looking at only individual risk behaviors, but we will look at it a little more broadly. And we'll look at the differentiated support for sex workers, which is how we've been able to address individual needs for young women selling sex, as well as other sex workers and their diversity. And then we will look, before ending, at the considerations to ensure program success and the lessons we've learned from providing tailored services for young women selling sex. Next slide, please. So the burden for HIV among female sex workers is about 4 times that of the general population, and incidence is estimated at between 5 and 10%. We also know that young women selling sex, and they are usually the newer entrants to sex work, are the most vulnerable to HIV infection. And so they need to be looked at with a different lens from those who have more experience in negotiating safer selling sex practices. The Sisters program is what we call the program that SESHA implements on behalf of the Ministry of Health and Childcare and the National AIDS Council. And it is implemented for sex workers and their diversity in facilities that are co-located with public sector facilities. And in that overview that Getrude gave, we saw that we are trying to integrate into the public sector and ultimately transition these into mainstream public sector. And so this helps being co-located in those facilities. In 2020, the program saw more than 30,000 female sex workers, and that's just over 2/3 of the population size estimate. There are also other implementers of sex worker programming in the country, and we try and offer a comprehensive program, which I'll talk about as I talk about providing the one-stop shop. As I mentioned, we look at addressing risk factors for HIV infection, and they are behavioral, including inability to negotiate condom use or drug and alcohol use, needing to have money and so not being able to negotiate the condom use with multiple high-risk partners, medical risk factors such as lack of contraception access or not being treated for an STI and not having access to HIV testing, or poor access or adherence to treatment and prevention biomedically. There's also structural risk factors such as sexual violence, experienced through clients or police, poor self-esteem, feelings, self and stigma, and experience stigma. And so we try and address this with a comprehensive program that addresses all these factors. The one-stop shop provides comprehensive services, sexual and reproductive health services, including STI management, HIV testing, and PrEP initiation and ART, and we transfer to the public sector after 6 months for stable sex workers. We also have community-based provision of services and take these services closer to the sex worker, and this has been really valuable during the COVID pandemic, where there's been restricted movement and also inability to access clinics that are decongesting and have to limit numbers. Microplanning, which I'll go into in quite a lot of detail in the coming slides, has been how we have now managed to optimize reach and engagement of sex workers in prevention and care services. And it had been successfully scaled up in other countries such as India and Kenya, and we've been able to learn a lot from this. The structural interventions have been important for looking at structural risk factors, and I'll also talk about self-help groups and what they've achieved in a bit of detail, as well as Friendship Bench to address mental health needs and looking at addressing gender-based violence through the Spotlight and the Lives approach, as well as child protection. So we've really been working also on building the capacity of sex workers to lead their own services, and we work with CBOs that we build the capacity of, as well as really strong sex worker leadership of the program. And across everything we do, we've had to see how you adapt for young women selling sex and for their particular needs. Next slide, please. So this is showing you this framework for what activities address which behavioral determinants ultimately and which target behaviors we are looking to achieve. It includes how the microplanners work, and they work based on SOPs that they are trained on, how they work within their hotspots, identifying sex workers and providing them with tailored support and supervision, and how the self-help groups address issues and have outputs such as improving problem-solving skills and working to establish cohesion within the sex worker community. Ultimately, we are hoping that addressing these behavioral determinants will result in improved clinic uptake with sex workers coming for their quarterly appointments, ensuring they know their HIV testing through regular testing, they take up PrEP and ART as appropriate, and that there's high adherence and condom use consistently. Next slide, please. So this is the flow of microplanning, this differentiated peer support that we found to be highly effective, where the sex worker peers identify sex workers in the hotspots and they map them. They profile how many sex workers there are there, but also by age band. And this helps us map the type of microplanners we need, whether the distribution is more of young sex workers or older sex workers. And then we have people who give them that individual support that they can identify with. The hotspot diary is where they list the sex workers that they're supporting, 50 to 70 each for a microplanner, and they make sure they encourage them to take up clinical services. They assess them for risk, and this helps us address those risk behaviors. They assess for duration in sex work, drug and alcohol use, how the person is doing well with condom use, and whether they've been experiencing violence, how many clients they have per week. And this is all done not in a, ask questions directly, but in casual conversation, building rapport and ensuring that they can get this information out of the person they need to support. Then they give them their tailored support by tracking them according to their risk. If they're high risk, they have to be seen every week. The lower risk are seen once a month. So the minimum support that is given is once a month. And they give tailored provision of prevention commodities, including condoms and lubricants. And it means that this young sex worker no longer needs to be going to a place to get these commodities. They get them delivered in the hotspot where they work or in the house where they live by their microplanner. They also get support for ART and adherence and referrals at each contact depending on what they need. And the outreach workers from the clinics then support the microplanners to ensure that the sex workers they are tracking are getting what they need and linking to the services that they need. Next slide, please. And so the sessions that are delivered by the microplanners are manualized to guide them on content, and they've been trained on all these content. And this particular image shows you the manual in English, but it's also been translated as well into Shona and Isindebele, which are the main languages spoken. There is a manual for all sex workers and their diversity that is used. This one was adapted specifically for young women selling sex, and it's called the Girls Club Manual. And it was because it was seen that there were sessions in the general manual that they didn't identify with, and they needed particular language and activities that really spoke to their own particular needs. Next slide, please. So the micro-planning ensures that we're nudging sex workers to stay safe by tailoring the services they provide. And the self-help groups are spaces where they meet, and I'll show you a little bit more about self-help groups in a minute, where they meet and identify their priorities as a group. And then they identify what they want to do in their groups. They give each other support. They can also access training through these groups. And it's peer-led. Some of them actually end up with structures in the group of who leads the group and treasurers if they're doing activities with money. And so the other important thing that I wanted to bring out is that there's data that's used to guide what the microplanner does. They look at how many condoms the person is using and with how many clients they say they are seeing to see if there's maybe low use of condoms. They then talk to them about that, see if they need to supply them with the condoms more frequently, and always looking at whether they've linked to the clinic. If they haven't linked to the clinic, the outreach worker lets them know so that they can encourage that person to link to clinical services. And we're really scaling this up now across the country because of how effective it's been. And having started with a pilot in Harare and then under 300 microplanners, we've scaled up to 600 in 2021. Next slide, please. So how does the self-help group work to empower them? They've really come across in feedback in the focus group discussions and in some structured interviews done with self-help groups that they really feel there's an emphasis on being a unit. They're stronger together. It's a space where they share practical tips, even on how to negotiate condom use with clients. And maybe if there's, prices about how they can set prices for sex acts. They've reduced competition amongst themselves in this way. The psychological resilience has been strengthened because they support each other and they address negative stresses. Also, the training that they receive from microplanners individually and going through sessions that equip them strengthens their individual agency. They received training, they formed internal savings and lendings groups to supplement their income, and they're able to have budgeting. There's some sessions, especially in the girls' manual on budgeting, which they have found to be really telling them things that they had never had exposure to in other settings in the home or in school that they found really useful. It's empowered them to link to services and to be able to coexist with non-sex worker members of the community because they often interact with them in the economic activities as well that they are now doing in their communities. Next slide, please. So here I just wanted to show how we've seen the scale up of the program since 2009 with the intensification of the program. And it's all been evidence-based. There's been a lot of research that's been done alongside the scale-up of the program. And we really have seen the increased uptake of services. Sometimes there's been funding interruptions and there's a little dip in uptake, but we've really seen the scale-up reaching a greater proportion of the sex workers in the country and increasingly high proportions of young women selling sex, where initially in the program, 2012, 2013, it was under 15%. And now close to 40% of those we see in the program are age 24 and under. And we've seen a reduction in STIs in the last 3 years between 2017 and 2020. That's been quite significant. And that's really, we believe, linked to the condom use uptake and also the consistency of condom use improving. Next slide, please. So I wanted us to pay some attention before I round up to some of the considerations that have informed how we've been trying to adapt programming for young women selling sex, and looking at some data on this slide that's from a prevention cascade analysis based on data from the Dreams Impact evaluation that was done in 2017. And some of the things that we really saw coming from that was that there was high knowledge about the efficacy of condoms in this group. And there was access to condoms, but the self-reported consistency of condom use was low. And so that's where we try to have micro planners give just tailored support for the individual reasons that someone may have difficulties with consistency in condom use. Is it because they have a permanent partner that they trust, and so they think they can't ask to use a condom, or they fail? Sometimes the risky sex is unavoidable because they've been really needing the money, or they have some alcohol use issues, then they forget to use the condoms, because we saw that that was quite a strong issue that came out. And the other issue was around access to condoms for those who did not identify as young women selling sex. And it may be because the microplanned are more often those who do identify. They're easier to access in hotspots that are mapped. So microplanners do try to reach young women selling sex now in homes where they work. Sometimes they're living together in rented accommodation and working there, and just trying to access them in non-traditional locations. The other thing that we've done to address this is to adapt the safe spaces. We have drop-in centers throughout the country for sex workers and across their diversity, male, transgender, female sex workers. But we found that the young women selling sex wanted their own safe spaces, and ones which wouldn't be traditionally known as places where sex workers hang out. So we have 6 dedicated drop-in centers that are called girls' clubs, where young women selling sex can come. We also were able to see from this data that women who reported experiencing sexual violence were less likely to use condoms. Those who had experienced violence, 43% versus those who had not, 60%. And we also really saw one of the reasons we are trying to emphasize also that these other structural issues like mental health issues must be addressed. And that's what we have done through Friendship Bench counselors, who are lay counselors trained to give mental health services on site at clinics and in the drop-in centers, because those who had common mental disorders also were less likely to use condoms. Next slide, please. So the key lessons we've learned within the program more generally, and specifically for young women selling sex, is the need for the integrated one-stop shop with comprehensive services. Referring from place to place for different things, generally we lose them in the prevention and the care cascade. And so it's really been an important thing that we've worked on, and it's taken some time to be able to get to have all the services available in one site. The differentiated peer support improves the risk reduction behavior. Having someone who gives you one-on-one support according to your needs. And so within the microplanners, we have those sort of Dreams age group specific microplanners that target that 15 to 24-year age group. There has been improved testing uptake when there's scale up as well of self-testing. That's really been helpful. Microplanners distribute self-testing kits in the community. And then there's follow-up by the outreach teams and clinicians for those who might need confirmatory testing. And we've seen uptake of testing increase from 14,000 sex workers in 2017 to 21,000 in 2020. Improved condom use and consistency in condom use is likely contributing as well to reduction in STIs that have declined from 14,000 to 10,000 in 2019. And we've really seen it's important to address structural determinants. If we leave out issues around stigma and sexual violence and mental health, we lose some opportunities to make progress. Thank you. Over to you, Humphrey.
Thanks a lot, Primrose, for that very detailed presentation and very well articulated. So, colleagues, we want to take some time, about 30 minutes, to engage with these 2 presentations. We have been watching the chat, but before we get to the chat, maybe we want to take a couple of questions so we interact with the presenters and hear what your takes are. We would want to particularly use these questions to guide our conversations. What is it that surprised you or impressed you or is of concern to you about the Zimbabwean approach? And how can we start to have across-country learnings and thinking about how we can practically apply these lessons that we have learned today? And particularly which conversations can now take place across or within countries. So just using these three questions to frame our discussions, I would like to open the session for engagements. If colleagues can show by a show of hands or unmuting their mics and interacting with the space. Any takers? So maybe while the floor is warming up, oh yes, please go ahead.
I wondered if I could just maybe some of the questions in the chat box, thank you to Tendai and Lillian, they've already been answered. I just wondered if I could answer one about difference between microplanners and peer educators.
Oh yes,
just
please
explaining
go ahead.
That we have had peer educators in the program since its inception, but they didn't offer differentiated support. So the main difference is the microplanner does risk assessments of each sex worker they support and understands their individual needs. So whereas perhaps the peer educator used to say, I just go and give everybody 100 condoms every week, they try to understand what do they need in that week. What are the difficulties they're facing and give tailored support for that individual level of need. And because they give that weekly tracking of meeting someone to provide that need, they do have a higher workload essentially. And yeah, as Tendai has already said, they get an allowance of $50 a month. And sometimes they end up having additional responsibilities in the program. It's possible to give them additional incentives if there's other work that they're doing so that they're not overloaded without being given any recognition for that. And then the other thing I did want to say about the numbers, there was a concern I think I saw about the number of 70. It's been seen from the experience in India and Kenya that they could track between 50 and 70 microplanners, and we found it also be effective. Not every sex worker in the cohort will be supported weekly because some are low risk and are seen once a month. We've seen that usually it's about 30 to 40% in the cohort is high risk, and the others are either medium or low risk. And whenever a microplanner is struggling with their cohort, maybe it's grown too big for them to give adequate support, the outreach worker who meets with them weekly identifies this, and we have to identify another microplanner to take over some of that cohort so that they're not overburdened. I don't know if there's other questions not yet addressed, Humphrey. Thank you.
So I'm not seeing any hands so far, but I would want to then, oh, Pari has a hand. So Parinita, over to you.
Thank you so much, Zimbabwe team. I think it's a wonderful presentation. I have quite a few questions, more clarification questions, but Primrose, because you raised the issue of microplanners, I just wanted to check. So are the microplanners key populations themselves? Are they sex workers? If the same sex worker is met by a peer educator and a microplanner, and maybe another outreach worker, I don't know if you have outreach worker cadre, does that get a little confusing for the sex worker who's met by many people to provide many services? I'm asking this question because in the context of Kenya, we train the peer educators to become microplanners. So I'm just a little curious as to, are your microplanners sex workers themselves or a different cadre altogether? Thank you.
Thanks, Parinita. Thanks, Parinita. Before I invite you to respond, Primrose, I want to share that colleagues on the team, on the Zimbabwean team also, please kindly feel free to chime in with responses on the chat or on this platform if you have any responses. And over to you, Primrose, if you take this one.
Thanks, Humphrey. So yes, Perry, the microplanners are sex workers, and the people being trained as microplanners usually have been peer educators already, because we started introducing microplanners in the program where peer educators were already working. So they've been trained in these skills and are now working as microplanners. In some areas where the numbers for the ratios to work out for the volumes of sex workers, we did identify and train as microplanners sex workers who were very strong in linking others into clinic and had strong networks, but hadn't worked as peer educators before. But yes, they are all sex workers. And it hasn't really been confusing for the sex workers who are being supported, because with the mapping of the hotspots, although obviously sometimes you have someone who works in 2 or 3 different hotspots, the listing in the hotspot diary is where the person then has their list of who they support. There's monthly meetings for all microplanners in a district. And sometimes they can then go through and just cross-check that they aren't microplanning the same person, so that they deduplicate in that way. And there have occasionally been some overlaps. And so then they'll see who has a stronger relationship with this person or that other sex worker and deduplicate that way. The outreach worker supports them and also attends the meetings they have, at times the self-help groups. So gets to meet them and hear if there are any problems, but they have less contact. The outreach worker is not necessarily a sex worker cadre. They may be, they may not be, but they're a full-time employee of the organization, and their job is to support the microplanners. So they're not the first point of contact for the sex worker, but they will sometimes meet with them in the presence of the microplanner. Thank you.
Thank you, Primrose. We'll take the next 2 hands, Grace Kumwenda, and followed by Grace, we'll hear from Fatima.
All right,
Grace, over to you.
Thank you so much, Chair, and thank you so much, Primrose, for the amazing presentation. I just wanted to reflect a little bit, I think, in the context of Malawi. For Malawi, I think the case is a bit similar to what Kenya has. We do have peer educators that have been trained in microplanning. They are responsible in doing risk reduction planning, risk reduction assessment. They do distribute condoms using microplanning as well, as you've presented. So I think for us, peer educators would be equal to microplanners in this case. But my question that I wanted to ask in your case in Zimbabwe, could you share perhaps in terms of level of qualification that you bring in for the microplanners? At what level of education are they? That's my first question. And my second question is just to understand, I know you are referring to the microplanners like this. So my question is, at national level, across different implementing partners, are they also called microplanners, or do you have different names across different partners? I just wanted to understand the harmonization and standardization of this cadre cadre among sex workers and the program. Thank you. Over.
Fatima, over to you before colleagues respond.
Hi, so I work with Grace, so our comments are actually similar. That's why I'm actually smiling. But impressive presentation and well done for the job that you guys are doing. In addition to what Grace just asked, she also asked those questions because we are in the process of reviewing our cadres or human resource in terms of KP. So that's why maybe she brought up all those questions. In addition to what she said, I wanted also to understand who identifies the microplanners. Is it the female sex workers identify someone that they can feel comfortable with to get services from? or the organization identifies and recruits. So the selection process. I also wanted to understand those microplanners that work across hotspots. The idea maybe to me was that it should be someone that they're comfortable with, they can approach easily, and they can access services at any point. And I'm looking at if one microplanner is covering across or more than one hotspot, I'm just thinking of the distance. Would that be a barrier, or the time if one needs a service at some point? And my last one is on engagement of law enforcers. Do you guys at some point maybe involve or conduct sensitization meetings with law enforcers, for example, the police and the courts, just to enlighten them on how they can work or protect female sex workers, MSMs, and just human rights around it, so that we have the law enforcers on our side, or the courts as well? Thank you, and over.
Thank you, Grace, and thank you, Fatima, for those questions. Can I invite colleagues to respond? Who's going to take this on behalf of the sexual program? Primrose, and while Primrose is coming through, may I ask Tendai to prepare to respond to our engagement with law enforcement agents on the KP program. Over to you, Primrose.
Thanks, Humphrey. I wanted to start by talking about the response to what is the level of qualification for a microplanner. We don't need them to have a specific educational qualification. We look for them to just be able to have some numeracy skills and literacy, so that they're able to read and use the tools that they use for tracking, that help them plan their visits and report back on what they've done with the person they were supporting, and also to be able to work in terms of looking at profiling hotspots and estimating numbers. So those are the skills that we look for. Everything else we found they can be trained on. You can train the microplanner to use the tablet to enter data, how to use the tool. With enough support, if they have those basic skills, they're able to learn the rest. So they don't have to have specific educational qualifications. Names of cadres are also probably Tendai as well might want to come in, or PSI colleagues. There are sometimes different names for people who do similar work. For instance, within just the sex work program, there's microplanners, but they also have been in a cross-border collaboration project that we have, where we try to ensure retention of mobile sex workers across borders into Zambia, Mozambique, South Africa, and Botswana, who are called peer navigators. They are essentially micro-planning, but have this additional responsibility of, they often cross the border themselves, and they navigate the sex workers to services in the destination countries and ensuring they get linked to treatment in those places. And there's also been term peer mobilizers and empowerment workers, but they're doing similar work. And maybe Tendai will have more to say about that. The other thing I wanted to talk about was microplanning across hotspots. We try to not have the microplan across hotspots, because the idea is to provide that level of support where you live and work to other sex workers who are in that place where you live or work. So it's just that sometimes you will have someone who will work in one place. You know, it's part of the dynamic way that sex work is. They will work in this hotspot, but they also work in another one a little way. Sometimes one hotspot is busy on this day, so I work there. And then the other one is busy on another day, and I'll travel and work there. That's how they'll sometimes end up with the same person in two hotspot diaries. But otherwise, the microplanner themselves only focuses on their individual hotspot. And then I think the last thing I wanted to say was, in terms of, I've lost my, I'll come back to it if I think I've lost the note. In terms of how we select them, how we select microplanners is those who are already engaging with services, because they're going to support other sex workers to engage with services. So we look at those who have linked to services within the clinic, who have a good, strong network. They need to be able to be someone who's got good rapport with other sex workers in the area. And so that's who we look at, and their clinic linkage is good, and those who we select for microplanners. Over to you, other colleagues, and Humphrey, thank you.
So we will hear from Tendai, and then we will go to the chat box and follow the thread of conversation that's going there. Just make sure we're not missing anything. Tendai, over to you.
Thank you, colleagues. Just to acknowledge that engagement with law enforcement and the judiciary is quite key. Sorry for that background noise. And in terms of Zimbabwe, we've tried to be really holistic in our approach and involvement. And we as NAC are co-chairing what we are calling the National Steering Committee for the LEA. And that's the Legal Environment Assessment. We are doing this project with support from UNDP. We did that assessment and we have a report, and that's what we are using mainly for engagement. However, you will notice that we haven't really moved far with our police, except that in 2017, we actually managed to do a knowledge and attitude and practice study with the ZRP, the Zimbabwe Republic Police. But after that, that study, that's when we had the coming in of the Second Republic. And you notice that there was really a huge shuffle within the police after the Second Republic came in. So we sort of lost our momentum. We would actually want to learn more from other countries if they are doing well around this. We've really struggled. And our entry point mainly when we are engaging with law enforcement is the medical directorate within the police. So it's been really a hard sell to try and go beyond, because, you know, as you engage with law enforcement, you appreciate that the police that do the arresting, are the ones that are within the operations department. So when your entry point, which is the medical directorate, is not really understanding and getting what you are trying to say, it's been hard, despite the fact that when we went to India, we were with the police. When we went to Ghana, we were with the police, but somehow we've lost that momentum, and we would really want to learn more around other colleagues around this to see how we can move forward. And then in terms of the judiciary, we've been having a very good partnership with Zimbabwe Lawyers for Human Rights. And if you are following our response well, you will appreciate that we actually had a case within the Concord where this judge put the burden of proof around loitering for the purposes of sex work. So these are some of the small things that we've managed to have on our side, but more still needs to be done. Beyond that Concord case, we haven't really done much. We still have more to do, and we would want to learn more from colleagues around that. Thank you, colleagues.
So thanks, Tendai, for that intervention. And I see some hands from Fatima again, and also from Pari. I will come back to you. I just wanted to get a look at the chat and maybe pick one or two questions that I see have not been addressed. We have two questions from the chat. One particularly speaks to what does the life skills package include? I think the SESHA team, this is addressed to you. And have you compared the increase in HTS in testing among sex workers and the young women selling sex? And do we have any lessons which can be applied across the two population groups? So maybe if you can take those, Primrose, and also one comment for Nigel or for the PSI MSM program. How can you adapt the identifiers in the DIC to community programs or providers? So I think there was an initial question before around healthcare workers wearing a branded or marked material. So what is your what is the recommendation around that, and any experiences that we could learn? I also want to draw attention to the national presentation that I think was delivered by Getrude, speaking to some questions around do we have plans for programming for trans and gender non-conforming persons? We also spoke about the National KP program, and it's really impressive. Are we using a UIC system that supports quality monitoring of data at national level? And if we do have one, could you share our experience of how that is working? So we have colleagues, I think, that can speak to these questions on the call. You also shared on the reduction of incidence rates at national level from 0.9 to 0.45, which is amazing. What game-changing strategies do you think led to these outcomes? So if it's possible, colleagues, may I ask that we tackle these questions on the chat box, and please, we can engage with them on this floor. Just checking in who would want to go first.
Hi, Humphrey. I could just quickly address the comment on comparing HIV testing uptake and condom use in older sex workers and the younger ones. I don't have the data readily available here, but there was, from the size estimation study, there is higher consistent condom use in the older sex workers than in the younger ones. And the associated reasons for that is the reduced ability to negotiate condom use with clients. And that's why that is one of the first skills that is focused on, is negotiating condom use with clients and how to judge condom use with permanent partners as well. So I think we would be able to probably share some follow-up data if I'll get that size estimation data, but I don't have it ready to hand here. Thanks.
Have we responded on the package?
Sorry, where about the package question? I've missed it.
We had a question on the, I think it was the curriculum that we're using.
On income generation activities,
Yes.
the more curriculum, Primrose.
Okay. There's a manual, there's guides for the self-help groups, and there's training for them in establishing ISOs or having income generating projects that they have. So it's manualized, and they get training on that, and they can request additional training if they have specific needs for specific things that group wants to do. And they get trained on how to manage the money for the income project, how to set up if they need to do banking. So there's training that is for those self-help groups, and there's also the manuals to support it. And we can share those materials. I think they might already be on the SESHA website, but I'll check, and we can also share them through the network.
Okay, thank you, Primrose. Nigel, there's a question around branding and adapting this to communities. Over to you, and then I'll come back to Getrude to respond to the questions around the national program.
Thanks, Humphrey. So one of the key things that we had to do in view of the COVID pandemic is also think about how to cascade the intervention beyond just the facility. And so you find that we adapted certain components. For example, the fact that we gave each one of our service providers a name tag, whether there are security personnel or they work with they interface with the clients on a daily basis, everyone was given this name tag. So what it simply means is that even when you go into the community, you wear your name tag so long as you are interfacing with the client. Some of the ways we have cascaded further, we introduced MiFi, because this is a service that we were offering at this facility in the form of Wi-Fi vouchers. So what we did, we procured some MiFi devices, which we gave the clinicians during outreach, and they can also offer clients Wi-Fi services whilst they're waiting to receive services. At the site, we had also introduced some refreshments, just some biscuits and some drinks. And we've also sort of come up with a way for people to get those refreshments during outreach activities. So we've pretty much tried as much as possible to cascade these services away from just being facility-based to being in the field as well. I hope that answers you. Thank you.
So thank you, Nigel. Getrude, over to you.
Oh, okay, thank you so much. I think the other questions I'll ask the other colleagues, especially on the M&E, to actually respond. But I'll respond to the game changer, what has been the game changer in the reduction of HIV incidence. Maybe as Zimbabwe, like we really used to have very high incidence as a country, but I think we've employed aggressive measures. The aggressive measures, the ones which we are talking about right now on issues of behavior change, I think together with our partners in National AIDS Council, we actually used to have even behavior change facilitators who will actually be discussing on issues of HIV prevention to the community. And even in schools, we used to have a school health program where we were actually discussing on issues of HIV and prevention. And then the other issue is use of condoms, distribution of condoms. I think we are one of the countries in the region which is, if you look at condoms which are distributed per annum, and we are actually looking at the use of condoms. And some surveys have actually told us, actually showed an increased use of condoms among even the young people. Then the other issue is the VMMC program. We have actually employed the VMMC program as early as 2009, and modeling has actually showed us the number of people whom we have circumcised is actually contributed to the reduction of new infections. And then we've got the DREAMS project initiative, which is supported by PEPFAR. But what we did as a country, PEPFAR was supporting maybe a few districts, but through Global Fund, through National AIDS Council, we actually emulated that DREAMS initiative into some of our districts in the country. And modeling has actually showed that we've actually been able to reduce HIV incidence through the DREAMS project. And then we've got a very robust, very good PMTCT program, elimination of mother-to-child transmission, where now our mother-to-child transmission rate is about 7%. And if we look at what was there before, around 20. So our mother-to-child transmission, like if you look at mothers who are actually coming for ANC, who are being tested, we've got a rate of about above 95% and all that. Although we are still struggling as well to have the partners tested, but with that mother-to-child transmission, we are actually having the partners actually coming for testing. And then I think the issue of partnerships as well with our NGOs, with like what we are hearing today, we as at national level, we have structures that we have this technical working group, discuss strategies, go and implement strategies, and come and find out what the progress has been done. I think the way we have this multi-sectoral coordination has actually helped us, all of us, to be knowing who is implementing what way and all that. And this actually, it is in the issue of just prevent new infections, and we have had that. So I think I'll ask one of our M&E cadres here who can tell us about the UIC, but what we have done now, we still have got a challenge with our indicators, especially the KP indicators within our national health information system. But we've worked out that now we know when we are testing, because it was just testing all, but now we have actually disaggregated to say this one is a KP, this one is a transgender and all that. We don't have enough information on the transgender, but I think Humphrey can tell us what we've been doing now to include the transgender within our KP programming. Thank you.
So thanks a lot, Getrude. Maybe I'll pick it up from this last note. I've noticed that colleagues have already responded to the M&E issues around the UIC and how that's been working on the chat. So we will not belabor that conversation. But I think increasingly our KP program is seeking to differentiate the offer of HIV, SRHR services to the other KP groups. So we have work that we started with the last round of the Global Fund grant, particularly speaking to addressing the needs of trans and gender non-conforming persons. And at this particular time, we are looking at conducting a situational analysis for people who use and inject drugs within country, and sort of getting to that situational analysis and motivating for a size estimation study at the earliest that we possibly can, harness funding. We have a program that we are doing with people in closed settings, particularly prisoners, but there's a lot of strengthening of that work that needs to be conducted with the support of the national program. So those are some of the weakest elements of our KP programming with those minority groups. But we have a very mature and robust sex work program and an MSM program. And I think one of the game-changing things that we have is that we have a very strong and vibrant civil society activity, that civil society networks that continue to hold us accountable and work along us with the national HIV response as providers of services within the communities. So it has really helped in ensuring that as a nation, we are able to navigate communities and reach to those members of our communities that would have otherwise been difficult to reach with the traditional HIV response mechanisms. I want to look at our time, and we are 5 minutes over our scheduled time for our engagements. I will take a hand from Pari and engage with this, and after this we will move on to the next session of our presentation. Pari, over to you.
Thank you, Humphrey. I was just lowering my hand, thinking there's no time. My question was to actually Nigel, and I really, really liked the way you all used human-centered design and created different archetypes for different MSMs. I was just curious to understand, did you actually train your peer educators or extend this understanding to the peer educators who could then identify during their outreach or peer education these archetypes and provide differential messaging to address each archetype? Just a clarity. Thank you.
Thank you, Humphrey. If I could take it.
Yes, please proceed.
Okay, so yes, we trained every person in the organization, including non-clinical staff, our HQ staff, because for PSI, this was really a groundbreaking opportunity for everyone to be aligned and speaking the same language. So everyone was trained on the archetypes. We did come up with some key messages, which we felt would be relevant. Yeah, I think that's pretty much it. That should answer your questions. Thanks.
So we want to get to the next phase. If you can go to the next slide. to sort of get a sense of your takeaways from the different countries. We have colleagues that are coming from Malawi, colleagues from South Africa, and colleagues from Ghana. What are sort of your takeaways from the presentations that we have heard from Team Zimbabwe today, and how best can we, collaborate further to find areas of strength, areas of weaknesses where we can learn from each other and cross-pollinate ideas? This will be open for we had a very robust engagement on the chat and also on this platform. So I take it there was quite a lot of, interesting things that we are thinking we could take away. Any takers to break the ice on this following section? And I think I will give it over to Dr. Byron Chimombe to support with facilitating this session.
Good afternoon, good morning, colleagues. So in this last section of our talk, we have had quite interesting discussions with the first the overview that we had, giving us the situation in the country, particularly zeroing in on the KP program in Zimbabwe. We've also had the PSI intervention, the colors intervention, the HCD study that was done, trying to tease out the MSM individuals that we need to reach out, and the particular interventions that we may need to use to reach out to them. Then the various service delivery models that are in use to also reach out to them and make it conducive for them to come to access services. Then we also heard from Seisha the risk reduction interventions, particularly around micro planning, and how these micro planners are working with clients to ensure reach and access to services, and working around their needs so that there is risk reduction and the services are tailored to what they actually intend to access as services. And I think the discussion has also clarified many issues around what the program is doing and what we might be able to learn. So this particular section, we need to probably have countries come up to share their learning experiences, platforms for collaboration, and what we may need to do in exchange to improve our programs and also improve the Zimbabwean program. Maybe we can have volunteers to start.
I see that Elliot has his hand raised.
Good afternoon, colleagues. Thanks, Kerry. And thanks for the presentations. I think my takeaway, or maybe more of an area of interest, was from the behavior change program presentation from Zimbabwe. And I was interested in how they are also using WhatsApp for communication. And I wanted to find out if they use it just for communication just between the peers and maybe the clients, or is there more like a group communication that they use? And furthermore, thinking about the time that we're in COVID and reaching people, especially key population, the platform could be maybe an interesting area to look at in terms of reaching more people. Thank you. Over.
Thank you very much for that. I think yes, it's quite important reaching out on the different platforms that are available. I don't know, maybe PSI, can you please respond to that?
Thank you. So I didn't quite get the second question. I think my network was hazy. But for the first question, yes, we have WhatsApp groups. So we have 6 KB implementing districts where we are operating currently. And for each of those districts, we have a WhatsApp group. And this WhatsApp group is, it's a social place. We send information, clinical, jokes, anything. It's really about creating a social platform in every sense. So we're not really strict about what needs to be posted there. Of course, nothing, no hate speech or no pornographic material, but it's really a social space in every sense. So yes, we do utilize these platforms as WhatsApp groups as well. I wasn't quite sure about the second question. If you could repeat that for me, thank you.
Yeah, I think the last part was just to say, you know, looking at the actual material that you then send on these groups, it'd be interesting to then look at those, the content itself, and see how how the model of the content is created. It could be more engaging or could be a learning opportunity there. Thank you. Over.
Okay, thanks.
So thank you for clarifying that part. So if we could hear from the other panelists or participants, what next step or important takeaway messages that we can learn or exchange from this deliberation.
Hi, Chair. I raised my hand. My name is Grace. So for me, it's been 2 key takeaways. The first one basically coming from the presentation on the PSI presentation where he talked about the human-centered design. I think I loved basically the way they went ahead to develop the campaign or the messaging for the MSM community. I think we do need to get a little bit more structured in how we develop messages for key populations in whatever format that we want to deliver them. But I think we need to find a way of developing them, the messages in a more structured way. The second thing that I would like, that I've taken away from the process has been from the presentation from Primrose, looking at the Girls Club manual. I think it really looked like a very useful tool and job aid that could be adapted and scaled in different countries as well. And I'm quite interested actually to look at the content and how adaptable it could be within the context of our program as well. I think for me, what was very critical for that was how they brought in a little bit more consideration in terms of working with young women setting sex. And I think that's an important element that we need to be looking at. So for me specifically, I want to look at that too and see how it could be adapted in the program that we're working with. Thank you.
Thank you very much for that, Grace. So the development of tailor-made messages for MSM, and I think the teasing out of various archetypes makes this messaging easier, and also makes the service provider or the community outreach worker design their messaging according to the design archetype. So very, very important. It's a platform that it will be very good to share and learn from. Also, you mentioned the user guide for the young women selling sex, also very, very important to assist in micro planning. And I'm sure that can also be shared, and with interactions and exchange, we can learn more from that. Any other takers? I see Chilongozi also has raised their hand. Please go take it away.
Yes, it's one takeaway is a presentation from Primrose. In Malawi, we usually, when we assign responsibilities to peer educators, we have been working on a ratio of 1 peer educator to 40 peers. So from a Primrose presentation, she's saying with a good risk assessment, you can raise that bar to 50, between 50 to 70. So that's something that with my Malawi colleague, maybe we may wish to look at that and try to explore whether it's feasible to increase the bar from 40 to around 50 to 70 peers per peer educator. Thank you, over.
Thank you very much for that takeaway. I think, yes, you are right. This actually is something that can be explored, making the peer educator more visible and stretch as much as possible. Although we need to be taking cognizance, what I think was highlighted also in the discussion, the issue of quality of service, if they have more clients to be following up on, ensuring that they are still capacitated enough to keep taking care of giving them enough service and enough care. Once and also the necessary support, like what was highlighted on outreach workers being there to support them. I note from the chat box, Jabulile is saying thank you for the presentations. Was also asking about HIV yield and what exit programs are currently underway for sex workers in the Zimbabwean program, and what programming is currently underway for young women under the age of 18. And also asking what strategies can be used to improve linkage to care, as they are highlighting it in South Africa. Maybe I may ask maybe Primrose to chip in and maybe respond to those questions as we're waiting for the next takeaway.
Thanks, Baron. I can answer yield in terms of what we're seeing with testing in the sex work program. It's been declining in the past 4 to 5 years, which we would hope to see anyway with reducing incidence. At the moment, we see yield of testing of between 7 and 10%. And I'm not sure about exit programs. I don't think we have anything that we call an exit program, but there are structural interventions for alternative income for sex workers that are set up through self-help groups. There's also, especially in Dreams implementation, even with the adapted Dreams districts, for vocational training, for second chance secondary education for those who want to return to school, and for being equipped with skills for earning incomes from activities other than sex work. Then in terms of the programming for young sex workers under 18, we do program in that age group between 15 and 19 years of age. And so we do this adapted programming that we was talking about for young women selling sex is within that age group. I don't know if I've answered everything. And in terms of linkage to care, I think also, and I see Gertrude has come in also with the national level yield of about 7% in 2020. Others may want to come in. In terms of improving linkage, as I said, with the one-stop shop, we found that we were not losing any, we were losing along the referral path, be referred for linkage to art, but then end up not staying at the clinic long enough or being lost. So initiating on site and also upon testing, even in the community, has helped to close that linkage gap to care. Others may want to come in. Those were my responses there. Thank you, Baron.
All right. Thank you very much for that response. I think you did touch on the questions posed I noticed we have heard from South Africa and from Malawi. Can we have probably a takeaway from Ghana? Anyone from Ghana to give us a takeaway before we can close? If there are none, I think, thank you very much for the deliberations. Thank you very much for the takeaways shared. I'll hand over back to Humphrey for the last bit of our session. Thank you.
Thank you, Dr. Byron, for this session. And it's particularly great to hear the reflections from colleagues about what they are able to take away. Before we close, we have an evaluation that we want to conduct with you colleagues to just get a sense of how the session panned out. So we are encouraging, please, before you leave, let's take this evaluation so that we can use this to improve the way that we engage with these Zoom platforms. But before we get to that, I wanted to invite Ms. Getrude Ncube to sort of give us a round of thank you. It's been an amazing session. We really are working under very difficult circumstances. We are in the middle of a third wave of the COVID pandemic in Zimbabwe, and it has not been easy. We are going through challenging times, and I want to appreciate the team that has taken all this time to put together this exciting and very interactive session. So without much further ado, maybe Getrude, over to you.
Okay. Thank you so much, Humphrey, and colleagues. I think you agree with me. We really enjoyed our 2 hours from 1500 hours. I don't know what time is there that side up to now. And thank you so much for the genetics for the South to South Learning Network for arranging this. And maybe I can say initially when we started this PSAT, we said, oh, these people are really bothering us and all that. But I didn't know it was going to come to this where we actually meet virtually and discuss our programs, what we are doing well, where we need to improve. Never think that what we actually discussed today, we are not taking it forward. We'll actually take it forward. And even your questions, they actually led us maybe to think further to say, how best can we improve? So thank you so much. And I would like to thank NAC, the civil society, PSI, all the civil society, as well as our Ministry of Health colleagues for this. We really would like to thank you so much. And you continue, you have got our presentation. If we've got any questions, please continue. I think Kerry has got our emails, address and all that. And you can even contact the champions for the South to South Learning so that we can still continue. We are hoping actually that we'll have other presentations as well for the South to South Learning where we have got countries coming in. Thank you, South Africa. Thank you, Zambia. Thank you, Malawi. Was there Zambia? Thank you, Malawi, and thanks Ghana for this. It's only that I was in a meeting where I was with Zambia. So thank you so much. I really appreciate. And Humphrey, thank you so much for sharing this so nicely and everything. We really would like to thank you so much, Genetics. Bye. And we meet next time. When is our next South to South Learning, Terry?
Gertrude, we will share with the team a schedule of upcoming.
Okay. All right then. But thank you so much. I think we learned a lot from all of us. Thank you.
So before we log off, kindly colleagues, if we can complete the Link and Learn poll that has been posted on our screens, we would like to thank you. I would like to hand over, is it to Carrie, the Secretariat with the SSLN.
Thank you, Team Zimbabwe. When colleagues have finished selecting their answers to the poll, you're welcome to log off, and we will be in touch via email with follow-up and some next steps. So thank you everyone. Thank you, Team Zimbabwe.
Thank you. Good day. Keep safe, all of you, wherever you are. Thank you.
Thank you.
Thank you. Thank you very much.
Bye. Thank you, colleagues. Have a good day. Bye.
Bye.
Thank you, colleagues.
And we are on time. That's good.
That's good, Gertrude. Exactly on time.
Yeah, exactly on time. Thanks, Barry.
Thank you. It was wonderful. Thank you.